There is no such thing as an EDS specialist. I've said this many times. All it requires is someone who's willing to listen and learn, potentially, if they haven't come across the condition before. But it's multi-systemic. So, the ideal place for this to start from is primary care. And I would just encourage, with any disease, and I say this, there is not enough listening that happens in the clinical pathway.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in connective tissue disorders like Ehlers-Danlos Syndromes, dedicated to helping you navigate hypermobility and live your best life. Today, I'm excited to welcome back Lara Bloom, President and CEO of the Ehlers-Danlos Society, and one of the most influential voices shaping the global future of EDS and HSD. Right now is an especially important moment because the Society's Road to 2026 initiative is actively re-examining diagnostic criteria and treatment pathways. The 2025 Community Experience Survey has gathered real-world patient data on a scale we've never seen before. The Society has taken EDS and HSD to the World Health Assembly, bringing these conditions into the global public stage. And the global registry and biobank are expanding rapidly, fueling major research efforts into genetics, comorbidities, and long-term outcomes. Lara brings the rare combination of lived experience, global advocacy, and organizational leadership, giving her a uniquely powerful perspective on EDS and where care is heading. In today's conversation, we'll explore what's changing, what's coming next, and what all of this means for diagnosis, research, equity, and patient care. This is a conversation you won't want to miss. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Okay, I am so excited to be here again with Lara Bloom. And how are you doing today?
I'm really good. And how are you?
I'm good. It's post-Thanksgiving weekend here in the U.S., so a lot of people had a little extra time off, which was nice. So yeah, and I'm so excited for this conversation. I've been wanting to talk to you for such a long time, and I have so many great questions. I think they're great questions anyway. So just super excited to dig in. There's been so much happening, I feel like, in the EDS space. So it's an exciting time to be doing this kind of work. And the recent research by Dr. Chip Norris and his lab has talked about, could hypermobile EDS actually be a neuroimmune condition? He says, is it actually that the immune system is actively dysregulating or degrading connective tissue? How does that research, and I know it's, one study, so we have to take it into context, of course, with all of these things. Has that influenced how the society approaches research, education, clinical priorities? And does that shift make you more hopeful than ever that we're going to actually be nearing a major breakthrough?
So it's actually not one study, it's more than one study. At the recent scientific symposium in Toronto, another partner of ours, ICR, who used the same Hedge samples as the Norris lab did, also found the same outcomes on actually a much larger cohort, which really, again, backs up this theory that we are looking down a different lens than we previously thought we were. And this immune dysregulation is incredibly exciting. And we're plowing a lot of money and time into more research into these areas to try and validate what these first few studies have found and replicate it and try and find out more. So, yeah, I think this is a really exciting time. It's really promising. I think that in the next 5 minutes to 5 years, who knows how fast, I think we're going to know a lot more. And it's because of studies like this. And really, it's because of Hedge. It all comes back to Hedge. All of these studies have used the Hedge samples. Everything that we have discovered or found or realized we haven't discovered, because not knowing stuff is as helpful as knowing stuff, has all come from those 1,000 samples. So that really paved the way to the direction of travel that we're in now for these conditions. And it's incredibly exciting. So I definitely remain very hopeful.
And there's people listening to this show who are brand new to the EDS world, and there's people who are very, very experienced and have lots of knowledge. Can you just briefly explain what the Hedge study is, just so that, or Hedge samples are, just so people have that framework?
Absolutely. So in 2018, we received a large donation of initially $1 million and then $2 million, where someone matched it, to whole genome sequence 1,000 people who met the 2017 diagnostic criteria for hypermobile EDS in the hopes of trying to find a marker. And we recently shared the first outcomes of the study, which showed that which wasn't a surprise, there was no found single gene causing the condition, which I think everybody was just looking for validation to confirm what people already knew. It didn't rule out that it was genetic. More work is needed. There's another phase happening now of Hedge, but as well as the actual Hedge study that was with an analyst at the Broad and with Christina Lakaitis, there have also been other studies that have used the same samples, ICR and Norris Lab being just two examples. There are others, Marina Colombi's work that also yielded some outcomes in Italy, and others. So I think a lot of people are now looking at these and trying to find answers. And we've had our first enrollment event for our global biobank. So we're adding more and more samples now, and not just blood, but we're looking at urine and skin and plasma and all sorts of things to really diversify the research that can now be done with the knowledge that we now have.
Which is really amazing. When we have a biomarker, it's going to make such a huge difference rather than relying on clinical criteria that are, sometimes subject to interpretation and some subjectivity. So I think that's just so wonderful. And thinking about the immune system and mast cell directed therapies, clinically, I have found, and I know a lot of other people have found, that mast cell activation can actually be the head of the EDS monster, not the tail. I've really found with my patients, when I treat their mast cell activation, kind of regardless of where they are on that spectrum, it seems to really make a big difference also with their EDS symptoms. Is the society looking at that? Are they observing similar patterns? What are your thoughts on MCAS, and is it universally present to some degree in hypermobile EDS?
I don't think we can say that yet. But I think what we can say is that there are a cluster of comorbidities that we see time and time again to be very prevalent in this time, and that is the mast cell, GI, autonomic dysfunction, and also bladder dysregulation. So we're seeing this pattern. We cannot say it's every person, and we can't say it's universal, but we can say there is enough that they are being considered when rethinking what the diagnostic criteria will be. Because for those that aren't aware, up until this point, there has never been any comorbidities included in the diagnostic criteria. And so what we had a Hedge and HSD criteria study that's been running the past few years, a multi-center global study, trying to find out first, is the current criteria fit for purpose? And if it's not, what should it be? And so that work is going to be part of the publication that's coming out at the end of next year, which is going to give us a new diagnostic criteria and classification for all the types of EDS and HSD.
Perfect, because that was my next question. You already answered it. So we're going to talk about the road to 2026 more, but that's going to be coming out the end of next year. So great. Okay, that's great to know. I want to talk about vaccination a little bit, because this is a surprisingly polarizing topic I'm finding in EDS and MCAS support groups, and there's so much misinformation. And given how much you travel and how much public exposure you have, I'm curious what your approach is to vaccination. And from the organizational side, does the society offer any official guidance?
So, personally, I'm definitely not anti-vax. I had my COVID vaccines. I have been vaccinated. I vaccinated my daughter. I believe in science, and I think we're very, very lucky to have the vaccines that we do have. However, I think that the COVID-19 presented a lot of challenges with the speed and the rollout and the process of how they came to be. And as a consequence, there was a lot of distrust and unease around getting the vaccines. I certainly had some complications from my second and third vaccine. I still had them because I believed that the benefit outweighed the risk. But currently EDS doesn't get you on what's called in the UK the shielded list. So people aren't able to get an EDS vaccine at the moment. And I think especially with recent studies that have come out, that's something that we would like to look at and see if we can advocate for that being a consideration. But it's different country by country, state by state as to how these things work and how people can get access to them. But as an organization, it's very difficult because we cannot impose what people should do. It's person by person, and whilst we encourage people to be vaccinated because that it could help, there's other reasons why people may not be able to get vaccines or want to. And like you said, it's a hot topic right now with varying different opinions out there. So we don't have a stance as an organization, and nor do I think we should. But we certainly, when during the COVID protocol times, when there was, people had to get vaccine to come to events, we followed all the adherence from the WHO, and that's really where we seek our guidance from. And follow the WHO guidelines. So that's really the organization stance on things. But it's difficult when putting on events. A lot of people are upset that we don't have compulsory masks at our events anymore. And the irony is that we did have for many years, much longer than other organizations were. And I think the last conference we had was Dublin, where we had a mask mandate. And I think that there were 3 people in the room wearing masks.
Oh,
And that was
really?
with a mask mandate. And so the point is you have to leave it to people's decision. We are not living in a climate anymore where masks are mandated. And I think everyone needs to have their individual opinion on these things. And we support and provide masks and support the wearing of them. But we found that even when they're mandated, people aren't wearing them. So it's really, it just makes life much more difficult because you're then saying there's a mandate and no one's following it anyway. So it's difficult, but I think everyone needs to do the best thing for them to protect themselves and those around them, and that's different for everybody.
And I'm so glad you brought up masking because I still mask on the plane. I mask, as much as I can because to me that's such a easy way of, at least maybe a little bit mitigating your risk. I went on a cruise a few months ago and I did get the COVID vaccine before I went on the cruise. And I was still so nervous anytime anybody coughed near me because I generally do limit my travel to some extent for that reason and even conferences and things like that. But I think it's the masking aspect is definitely something that can be low risk. I mean, I know some people react to the fabric of the mask and things like that, but I think it's something that is definitely underutilized. And even just, I don't know if you've observed this, but on a plane, people sneezing and they're not sanitizing their hands or whatever. And obviously there's issues with sanitizer, but, just basic hygiene. I feel like during COVID, there wasn't enough emphasis on that and like stay home if you're sick, if you possibly can, kind of a thing. So I think often we do talk about vaccination, but we don't talk about some of those other things that we can do to help each other out.
Exactly, and I travel a lot, as you know, and so I did mask for a while. I don't now. I have found, touch wood, I haven't had COVID now for a good few years. I had it 3 times at the beginning, and I all of those happened when I wasn't traveling. They were at home.
Oh, really?
Yeah, and so I take very high dose vitamin C every day, and I notice a huge difference if I even miss 1 or 2 days. I am all about the hand sanitation. I go everywhere with my sanitizer. I try not to hold doors. I kind of put my clothes there, and
Yep.
um, and I am mindful if there's people coughing or sneezing, I'll just choose to step away. I think the reality is, though, what I found, and it depends what kind of mask you're wearing, but if I was ill and I wasn't, I didn't have COVID, or if I was sneezing, I would more likely wear a mask to protect others because that, I think, has more evidence in helping versus wearing a mask to protect yourself from others. Because unless you're wearing the N95, you're not really going to, protect yourself from everything. So I think it's more for when you may be unwell or run down and being mindful of others that a lot of people these days are wearing a mask. But yeah, it's difficult, and the amount that I travel, I'm very lucky, especially as I have two immune conditions. I just really look after myself when I travel, and I have, touch wood, stayed okay. But for me, it's that vitamin C that is the difference.
Yeah, I'll tell my husband I think right now I'm about 2% sick, and I'll go and I'll increase my vitamin C, my vitamin D. I have a whole slew of things that I take, and generally speaking, yeah, like you said, touch wood. Uh, I generally stay very healthy. Would you be willing to share what your dose of vitamin C is? I'm sure there's people that are going to ask.
Yeah, and always consult your health
Of
professional,
course, yes.
but for yours. But I went on a trial many years ago for vitamin C, with my immune deficiency that I have, which is MBL deficiency and pneumococcus deficiency, because I was getting pneumonias 2 to 3 times a year. And at that point, I went up to 5,000 milligrams a day, which is pretty high powder, and I didn't have a pneumonia from 2014. No, it's from 2011 until COVID, based on just that protocol. And then I got COVID, and then I got pneumonia. But my day-to-day amount is about 2,500 milligrams. And then when I travel or I'm run down, I bump it back up to 5,000. And you just got to make sure you're really well hydrated. And other than that, I haven't had any issues. I make sure I take the powder so it's very clean. It's not, uh, in a pill form, because sometimes they can add other stuff. But I really feel like that's night and day for me when I'm on that. And there's a lot of evidence now on the benefits of vitamin C on connective tissue. So I'm really, intrigued as to what that is. And I know in vascular EDS, that's a vitamin C is part of most people's protocol. So I'd love to know more about why it helps me so much, but it does, and I'm not messing with it.
Yeah, yeah. It also helps stabilize mast cells. And we know that humans can't make extra vitamin C under stress like some other animals can. So it makes sense that we do need more when we're stressed. So thank you for sharing those extra details. That's really helpful. We're going to definitely link some of those Hedge studies to the BendyBodiesPodcast.com website. Do you have other updates on either Hedge? This could be 2 hours by itself. Updates on Hedge, the DICE registry, or other major society-led initiatives?
So there's a lot going on right now. I would definitely encourage people to check out our website on the Hedge and HSD criteria study updates, the Hedge page. All of our updates on those research initiatives are on there. As I said, the biggest finding that came out of the Hedge study is that they couldn't replicate the Calcrane, the KRK15 finding that the Norris lab found. There was nothing with the THR genes, and they also there was another one that they couldn't, that had been looked into, the Tenexanex gene as well. So it was more telling us more validating what we don't know than again what we do know. But it also showed that there's more things to keep looking at. Um, and so I think that's exciting. And then, of course, this immune dysregulation work that's coming out, that um, a lot more research funding is going into that area. So I'm hopeful that that's going to yield some really exciting results. The DICE registry we have around, or total now, because we've got some legacy registries from when we were on a couple of other platforms, but we're over 20,000 people now are on the DICE registry, which
Wow.
is unbelievable. The
Wow.
largest collection of people with EDS and HSD ever. And we've got our first couple of hundred people enrolled on the biobank, and the aim is to have 1,000 people by the end of next year. So that's going to be even more samples that people can use and study on. I think the biggest bulk of work that we're focused on right now is the road to 2026, and that's really taking up all of our time and energy, and focus, and things that are happening in parallel to that, that may come out before the publication and may impact it, or may not. So You just have to go with what you know right now. And all of the committee and the consortium are working on everything related to that at the moment. So almost a year and 2 weeks left until that comes out.
And speaking of the road to 2026, I know that so many people are, looking forward to it, but also kind of nervous about it. It's going to be, like you said, producing this, updated classification, diagnostic pathways, et cetera. What are you thinking are the biggest scientific and logistical obstacles to achieving those goals? And what should patients be aware of and or what can we say to maybe alleviate some of their concerns? Because I know when people hear about this, they often get really anxious about it.
So obviously I can't say too much. Everything is embargoed until the publication. That is not the society's decision. That's how publications work. But what I can say is that this work was done. When the 2017 criteria came out, there hadn't been one for 2 decades. And everyone knew that change was needed. And there wasn't the level of funding, capacity, or collaborative efforts that enabled us to know more than what came out in 2017. And it was really more of a research criteria than anything else. And it led to things like Hedge, which have led to all this discovery. So we had to do that to have some breakthroughs and make some headway. But I think over the years, what has come out of it is that there's a lot of gray. And people aren't clear, what is HEDS, what's HSD, is there a difference? And the HEDS and HSD criteria study recently announced at the symposium that the initial results that we can share is that it looks like HEDS and HSD are one in the same spectrum, one in the same condition. Now, what does that mean? What will it be called? What will it sit under? How will it be classified? Will comorbidities be involved? All of these questions are what is being worked on now. So now we know it's one in the same thing. Now we know there's not a single gene causing it. All these things that we're knowing from all these parallel studies. And also, I say it's the society have funded and facilitated this work. There are 3 or 4 of us from the society that have a seat round the table, bringing our lived experience expertise and bringing all of the data that we have from our community on the reality of what it's like to live with these conditions right now. That's our role in this. Our role, we don't have a vote, so we don't vote for the outcomes. That is left to the independent experts around the table. We don't decide what things are called, how things are classified. Our role in that is to say, this sucks right now and it needs to be better. And these are what the issues are. And these are what people are facing in Sweden, in America, in Africa. And, this is the reality on the ground. We're telling you the narrative. You're bringing the science and expertise. And then how can we facilitate that to come out in this publication that will hopefully improve diagnostic odysseys, the time to diagnosis, and getting closer to models of care and diagnostic realities that when you are diagnosed, that you have management and care. And that's not the reality right now in most of the world. So it can only get better. But sometimes to get better, there has to be change. And so what I can say is change is coming. And we all have to hold on tight because, I don't know exactly what that change looks like now because the work is still ongoing. But I do know that change is coming. And as someone that lives with this as well and is diagnosed with hypermobile EDS, I'm going to be impacted too by whatever that change will be. So, as a patient, I also have anxieties about what that means. As the CEO of the organization that's going to get the community through these changes, I have immense anxiety and concerns. But what I do know and what I believe in and what I feel very strongly in is that this change is needed, it's necessary, it's important. And although it might be difficult in the beginning to navigate the change, just because change always is difficult, I think it's what's needed to take us all to the next stage. And I think it will be a positive thing, albeit, we are now in a position as an organization where we have the funding to rely on partners and external stakeholders to help us tackle the challenges that any change will bring. So, we could have found a single gene marker for hypermobile EDS, and it would still be change and it would still need navigating. So I'm not necessarily preparing people for anything bad. It's just whenever there's change, you have to think about ICD-10 codes, ICD-11 codes, insurance implications, access, primary care, diagnostic pathways, the European reference networks, every other national organization out there. So there's so much to consider that, of course, it's going to impact everyone on some level. But I am optimistic and I am hopeful. And I do believe that change is needed. And our role in it is, like I said, to bring the voice of the community to the table and then to take the science that they bring and to try and communicate that and embed it in the best way for the first time ever, I believe. I believe that we have the people and the tools for the first time ever to actually have a stab at systemically changing the reality of access and diagnosis with these conditions. So I'm excited. I'm already tired for next year. I'm exhausted for 2027. But we just keep going. And if I thought this year was busy, it ain't nothing compared to next year. I just can't even look at my calendar for next year. It's almost fully booked until this time next year.
Wow, that's
But
crazy.
it's good. It's good. I'm ready for it, and I'm excited.
And that fits in perfectly with what you said last time about the first 10 years kind of laying the foundation, and now you're able to just do such incredible things. And you're still in your garden office, right? I think I heard like a little ambulance go by or something. I hope that person is okay.
Yes, still in the garden office.
So that was so beautifully stated. And I shared something on the podcast about, I have a hypermobile EDS diagnosis, and I was sharing that, my diagnosis might change as well. So, I don't know. I'm a patient too. So like you just said, so a lot of people though, after I talked about it on the podcast, there were some people that were very upset. And so I really appreciate you sharing a lot more about the process. And we want people to be accurately diagnosed. Having a diagnosis, if it's not accurate, is not helpful to you, and it's not helpful to the community at large. So that's really what we need is we need things to be defined as well as they possibly can be. And then we need individual people to be as accurately diagnosed as they can be so that they can get the help that they need.
Exactly. And I think the reality is there isn't anywhere right now where having Hedge or HSD gives you access to what you need. There's issues with both, and there's issues culturally and geographically different all over the world. In somewhere like Australia, for example, and some places in London, if you get to the right clinic, there's no issues with you having a diagnosis of HSD. In other places in Europe, you're not going to get anything. So, and then there's other places where they won't even use the term heads. It's just, they believe it's over medicalizing and over diagnosing. And I think the reality is, whatever it's been called, a diagnosis matters. And it gives you validation and it gives you an understanding of what you're living with. And so whatever it's going to be called, it's a kind of irrelevant, the actual words. What our job is, the society, is whatever that diagnosis means, it means it gives you credibility, validation, access to diagnosis and access to care. And right now, neither Hedge or HSD necessarily give you that. So whatever the change will be, it's, not likely to be anything new or either one. I don't know how it's going to land. I guess what I'm trying to say is it can't get worse than how it is right now. And I think it just people need to accept that we have to move forward. And all of these studies that are happening right now are going to inform those decisions. And I think critically, we are, again, our role in this is to say to the scientists, well, in your opinion, it might not be important what it's called, but the reality is it is important. And it is important that however it's termed, however it's classified, however it's described, is accurate representation of what people are living and experiencing every day. And so that's where I come in. That's where the organization comes in, the people we've got around the table of saying, that's the detail underneath the scientific decisions are where then we can play a role. And I think it's important. I think diagnosis means a lot to people, and I completely respect and understand that. As someone that waited 13 years for mine, I know how much it means.
Yeah, that was a pivotal point for me getting the diagnosis because suddenly everything makes sense. And it probably was papers of yours that I was first reading when I didn't know what was going on with me. And I started, just like a lot of people, started reading different things and going, wait. I mean, I was a physician. I was working as an anesthesiologist. I had learned about, Ehlers-Danlos in medical school, like most people say, a couple sentences, whatever. So yeah, it's pivotal when you actually have a name to put to what you're feeling in your body. And I want to talk about the 2025 Community Experience Survey. On the website, it wasn't clear to me if it's still open or not. Do you have something that you can share about that, and also why you think it's important for people to register on NICE?
So it's not open anymore. We used the data from that to help us with this process. That was how we brought the community voice to the table. And critically, it is one of the standalone papers in the publication next December. So the community experiences are going to be published as well as the scientific outcomes, because as a professor in lived experience and patient engagement, it was very important to me that we brought forward the lived experience of what these conditions mean.
Ah, excellent. We're going to take a quick break. And when we come back, we are going to talk about what Laura's advice is for clinicians who feel unprepared to manage complex EDS patients, what they can do, because we know that we have a lot of clinicians that listen to this show. So we're going to take a quick break and we'll be right back. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we are back with Lara Bloom, and I'm so excited about this road to 2026 because I do feel like it's so desperately needed. I remember when the announcement was made with the 2017 criteria. It was you and Claire Francomano, right? Dr. Francomano, who had, and I was like, oh my gosh, this is going to be huge, and this is probably going to upset a lot of people. I was at that 2017 conference in Las Vegas, and it was quite interesting, but it's so exciting to see how the research has been growing and all of the incredible projects that the society is involved with on various different levels. How does the society decide and prioritize which projects to advance?
So it's really based on funding, on the kind of funding we have. We have something called a research inner circle, where we encourage people to submit proposals, researchers, academics out there. And then we have a pool of high net worth donors who then look at those proposals and decide what they want to fund. So at the moment, being at the mercy of an organization which has no government funding, no industry funding, we are reliant on individual giving. Now, where we get research funding that's unrestricted, we then will do an RFA, which is a request for applications, and then it's much broader. It's we have an independent scientific committee that then decide on what gets funded. Any proposal that comes through the inner circle is vetted by our chief scientific and medical officer, and our medical and scientific board monitor all the outcomes and the reporting that's done. So there's a lot of good governance around it, but ultimately we are at the mercy of having only that type of funding available to us. So there is an element right now where there's a huge influx of research going into Hedge and HSD. because the donors we have children with that condition, and they are emotionally invested in trying to make their children better. And that meets our mission and matches our research priorities, so we're happy to do it. But it does mean that we don't have nearly as much as we would like for the monogenic types, the rare and ultra rare types, because currently we don't have any high net worth donors that are giving in that area. So, in an ideal world, we would be giving equally to all the types of EDS, but like I said, right now that's not the reality. If there are any high net worth donors out there that are emotionally invested in those other types, please reach out, because we are here ready with our governance structure set up, ready to give out that research funding. So it's a good, listen, we've funded $40 to $45 million in the last 5 years in research. I mean,
Wow.
we've done amazing things. And when you think
Yeah.
that that's just from parents, it's as extraordinary. And I'm really proud of us, especially as when we launched this, the most we received one year was 25,000 for research. So
Wow.
we've come a long, long way, and we have made possible all of the discovery pretty much that has happened in the past few years. In some way we have been behind, and that's really exciting, and that's something we're really proud of.
As you should be. That's tremendous progress in such a short period of time. And we know that more patients are getting diagnosed earlier. So long-term outcome data would be something that would be really, really helpful to have. Do you know if there's plans for natural history studies or expanded longitudinal registries to track these trajectories, complications, et cetera, over decades even?
Yeah, so we launched a natural history study at the end of last year. It's initially looking retrospectively at data from Claire Francomano's clinic at GBMC and at IU. And we have intentionally paused the the prospective collection of data until the new criteria is published, so that it all then matches the right terminology and it is with all the changes. It seemed redundant to do something for a year and then all the data points be changed, because obviously it's all going to be done through the registry. So please watch out for that at the beginning of 2027. That's one of the first things we'll be launching, the surveys to join that natural history study. We don't know enough, so we're really excited for that data. And the other big study that will be launched as soon as we can after the publication of prevalence studies, because no one has a clue how many
Right.
people are actually living with this. I think
Right.
it's safe to say now that that globally agree that Hedge and HSD is not rare. But how common is it? And how rare are the rarer types? So we just can't answer it. You've got this, the only published figure is this 1 in 5,000. There's been other attempts at trying to get a number, but they've not been done right. They've concluded EDS is not rare. Well, that's ridiculous, because all of the types bar one are rare. So they've just, it's been, we've got to be very careful what we say when we say EDS isn't rare. Hypermobile EDS isn't rare. All
Right.
the other types are rare and ultra rare. So I think some really reliable, well done prevalence studies are going to be our priority next year after, 27.
And speaking of the 2026 guidelines, do they include sex and gender specific considerations, things like hormonal influences, difference in symptom presentation, documented healthcare biases? We know that there's differences in access to care. Do you know anything about that? And I know that there's only so much that you can say. Is there anything though that you can share about underrepresented populations?
So we will be announcing something soon that I can't talk about at the moment, that's going to be looking specifically at models of care. And that body of work is going to really be where those issues are tackled. In terms of the actual publication, I can't go into the details of what will come out of those. Then they're being written as we speak. They're not written yet, so I can't comment, and some of them haven't even started because they're still building the evidence and doing literature reviews. But I know that Dr. Claire Francomano is doing a hormone study that will be very interesting when the results of that come out.
It was so exciting to see that you addressed the World Health Assembly about diagnostic delays, barriers to care, inequities, and the mental health impact of these fragmented systems and complicated conditions. What do you think the key message was that you brought to this global stage, and what was the real world change that you most anticipate?
So I don't anticipate the change immediately. We've been attending now. I've been attending the WHA for a good 3-4 years, and this year, each year it gets a little bit more EDS being part of the conversation. But it's largely been through me being on a panel at other people's events versus the topic being EDS. However, because of attending all these events and because of the networking and collaborations that have happened, in the next couple of years, in May 2027, EDS will be hosting our very own event at the WHA, all about the
Oh,
new
wow.
diagnostic criteria and models of care. And that will be part of the announcement that we make soon about the models of care work. So watch this space, incredibly exciting. And I think so in the next 2 to 5 years, that's when I think we'll start to see that change ripple out and the domino effect of being able to have a seat at that table.
What do you suggest for clinicians who are just learning a little bit about these conditions and maybe they feel like they don't have enough tools in their toolbox and they want to help patients? And I want you to talk a little bit about the ECHO program, of course, but what are some different levels of ways that they can learn more so that they can actually make a difference in their patients' lives? Because this whole there's nothing you can do message that we keep trying to debunk is something that I still see over and over and over again.
I think the first thing I'd say is don't be scared of us. We're not scary. There is no such thing as an EDS specialist. I've said this many times. All it requires is someone who's willing to listen and learn potentially if they haven't come across the condition before. But it's multi-systemic. So, the ideal place for this to start from is primary care. And I would just encourage with any disease, and I say this, there is not enough listening that happens in the clinical pathway. And so if people listened and validated what the people in front of them were experiencing, I think we'd receive much less times in that diagnostic odyssey. But I think, understanding that a female can walk into your doctor's office with a racing heart, GI pain, and a bad knee, and it's not anxiety. Um, and to not see each issue as an individual presentation and to actually put everything together and think about what could be causing everything. And sometimes there isn't, but as we know with EDS and HSD, there is. Um, and equally, what can be just as dangerous is when you do have a diagnosis and then you have issues that come up. Everything is then put down to your EDS and
Right.
HSD. And
Right.
then, some really significant health issues can be missed because it's like, oh, it's just because of your chronic health condition. So there's a balance there of how people need to be tuned into that. And I think it comes back to advocating for yourself. And, I wish we didn't live in a world where people were so threatened by educated patients, but we live in that world and doctors don't like it. And I would urge them to see that instead of a threat and something to be frustrated by, to instead see someone in front of you that's clearly been working through a lot of challenges and barriers to get the care and answers they need, and that this is a person that really needs you to sit and listen to what they're saying. And I think if we introduce listening as the first point of care, we'd all be a lot better.
Yeah, that's so well said. And I think that's fantastic advice for clinicians. Do you have advice for patients who are trying to get their clinician to listen?
I think I always recommend going with a list, and as much of that list can be, again, overwhelming and threatening to a doctor, what always happens is you get into the room and you forget everything, and you're like, oh, and I didn't mention this, and I didn't mention that, and to try and, even if you say, could I email this to you? Could this be put on my file? Can I leave this with you so that it's logged somewhere, this myriad of symptoms that you're experiencing? I also think it's important to say, you know, I've been looking at this. What do you think? Do you think this could be something, instead of, this is what's happening, and, almost not caring about their opinion. And I found that I've had much better reception from people when I've kind of had that approach. So I think it's a really hard time to be a patient, more than ever. It really is. And I wish I could give more hope and kind of pockets of wisdom for people, but it's tough. But I would, try not to rely on Dr. AI and Dr. Google. Try and understand your rights of being able to keep requesting for another doctor and a new person to see, because you have that right. Um, and just, look online about self-advocacy and what to do about advocating for yourself in those situations, because there are support out there. There is support out there to help you through that difficult process.
I think another thing that I try to stress with my patients that are, seeing other clinicians and then they come back and report negative experiences, that as much as possible, and it's obviously harder to do than it is to say, but trying not to take it personally. I even went to a doctor's appointment with a family member who does not have EDS and is very straightforward, had a very straightforward problem, and even they got gaslit. The orthopedic surgeon looked at the images and was like, "It's not that bad," and then looked at the images for the knee and literally said, "My knee is worse." It was like,
Unbelievable.
yeah, unbelievable. And this was a male. We know in general females are not treated as well as males. So this was a white male. So they had like more things going for them, and yet that still happened. So I think that if we can try not to take it personally, and also try not to gaslight ourselves, because I know that for me, not now, but before, when I was really frustrated and so much pain and trying to navigate all these symptoms, I would give the doctor too much power over me. And if they were not believing me, then I would stop believing myself. So I think that believing in ourselves and knowing that we're feeling what we're feeling is also really important.
I agree.
Yeah. And speaking of advocacy, one of the followers, listeners asked me to ask you how other people can get involved in EDS advocacy.
There's a few different ways. On our website, there's a Get Involved button, and there's the Echo Advocacy course that's happening at the moment. There's also other ways to volunteer, share your story at our events online. There are ways to do professional advocacy as well. I believe that information is on our website, but it's never been a better time to be an advocate and want to try and professionalize that. I think there's lots of options out there. Listen, everyone always says, how can I do what you're doing? And I think I am an advocate, but I'm a CEO primarily. I run the organization, and my advocacy is still, to a certain extent, something I do on the side, because it's very difficult to get a job that is paid and that you can advocate full time. I've been in this field now 15 years, and I started as a volunteer, and I started as an advocate, and I started as someone that just needed something that wasn't there. So I tried to build it. And I think you have to move from the point of just telling your story to being the voice of many. And that is quite difficult to do. I very rarely talk about me anymore, and sometimes I forget I have the condition because I'm so busy talking about other people's experiences, and I'm like, oh yes, and I people say, how do you get into this? And I'm like, oh, and I have it, and so, but it's not what I lead with, and I think that that's the difference of kind of professionalizing it into a job. It's no longer just your narrative and story, and advocating for many. And I think that there's options for both, and neither are more important than the other. It's just different options of how you want to advocate.
We know that so many people with EDS and HSD live with significant financial strain. Can you highlight the society's free or low-cost educational resources, so that people know how they can utilize them?
Sure. Yeah. I mean, all of our information on our website is free. We have a YouTube channel as well. We have webinars, we have videos, we have translated content. We have a lot of events, and they are paid for because it costs a fortune to put on events. But then we have scholarships for every single one of our events. And we also then have the content available online for free a period of time after that. So check out our website, check out whatever area on the body you're interested in. And then we have lots of there. We also have something called Claire's Corner, which is Dr. Claire Francomano doing loads of educational videos about learning and understanding more about the condition and the comorbidities.
Okay. And then can you also talk about the provider directory? Because when I asked for questions to ask you, and I got lots of great responses, one of the people responded that they were frustrated over the provider directory because they must have come across somebody who, at least in their opinion, did not have much in the way of expertise on EDS and HSD. So can you explain a little bit about how that directory works?
Sure. So we cannot manage and maintain every person on that website. What we have done is provided a space where people can find out who is out there, and then it's up to individuals to look online, look on forums, look for feedback, look for reviews, and make the decision if that's someone they want to see. It for us to I mean, it's just not our role as a nonprofit organization to be the people that determine people's experiences at these clinics, because someone might have a fantastic experience and others may not. We also don't add people to the directory, so people have to add themselves. And we have a disclaimer on there for that reason, because we cannot give absolute conviction of the clinics and the services they provide. So you have to use that with that knowledge and then do the research that one does when deciding whether to see a healthcare practitioner.
Are there any other thoughts about the road to 2026, the updated criteria, and people who, like you said, fall in the gray zone, how the society will communicate changes in a way that respects people's lived experiences and prevents fears over losing diagnoses? And are there going to be any pathways for patient feedback or community input if the new criteria fails to reflect certain phenotypes?
Listen, everything we're doing is trying to represent the voice of lived experience, um, and to make things better. That is the primary goal of this entire effort, to make things better. It's in no one's interest to create something that is going to make it harder for people to get diagnosed. Um, we're going to be doing a hell of a lot of work in providing resources, toolkits, webinars, events to communicate this information for people to understand what that means for them. We're also working on various other things, like I alluded to, that are going to be announced over the next year. People we're partnering with, efforts we're making to really make this land. And we're also then holding something called listening labs across 2027, which we're holding one a quarter in every region, where we are inviting people to tell us the reality of what this diagnostic criteria change has meant. And in an effort to have real-time feedback of what that means, and these things are never final forever. It takes years. It's been almost a decade since the 2017 one, but if we start hearing on the ground that X or Y just is not working, or there's this new challenge that hadn't been thought of, there could be things that as an organization we can then do, lobby, advocate for, that can improve those things. So rather than change science, because that's the point here, we can't change the science, but we can change. We will try and then change and have impact on what that science means and how we can make it accessible. So yes, we're going to be listening and learning with the community from day one of those new changes.
You already talked about how wonderful it would be if there's people that could fund research on the rare types. If funding was unlimited, what moonshot initiative would you launch to transform EDS and HSD care worldwide?
Oh, goodness. I think it's all got to be about the therapeutics. There's no therapeutics at all out there. I'd love to look at, and we are starting to look at, drug repurposing, gene therapies. I think gene therapy would be the ideal moonshot for the monogenic types, because we know the thing causing these conditions. But therapeutics for symptom management is really where I'd like to go. And we've got listen, we've got so many things that are going to be announced over the next year or two that I really hope will start having more of an impact in real time to people, because I understand that all this research, be it incredible, people aren't necessarily immediately feeling the results of it because we don't yet have a marker, for example. So what can we do to try and get things to people more immediately? So we're working on that kind of thing, and at the moment on how we can do that.
Yeah, and that's a big reason why I started this podcast. I would go to meetings and I would hear, in particular, like the ASA, when I was, still working as an anesthesiologist, go to the ASA, American Society of Anesthesiology meetings, and sit there and listen to these researchers and people sharing fantastic work that they were doing, but yet recognizing that in the clinical practice, this wasn't getting translated and there were such long delays. And so it's great to be able to talk to people like you and get that information available to so many, thousands and thousands of people that wouldn't otherwise get to hear it. So thank you. That's really helpful. And what does success look like in 5 or 10 years for the society, for patients, and for future generations?
People getting diagnosed when their symptoms begin, and then when they are diagnosed, having a care pathway, both for their physical health and mental health for life, not just for 6 weeks, as is often the case right now. So care for life, the right care, and that validation.
Okay. Was there something that you were hoping that I was going to ask that I did not ask you?
No, I don't think so. I think, listen, there's so much I wish I could say, and there's so much I wish I already knew that I could share. Like I said, we're in a bit of a transitionary holding spot right now. But I'm hopeful that all the changes will be for the better, and that people will eventually, because of those changes, get the care and diagnosis that they need, and that this condition will actually be one that's respected and credible and believed by so many people out there right now that just don't take it seriously. Um, that change is already beginning, but I would love to get to a point where nobody rolls their eyes when they hear this condition. That would be a massive win. It's very hard when you go to places and people just don't get it. So lots of educating to do, but like I always say, the hardest part is the amount of re-educating that we've got to do. And so I'm excited to have this new criteria, new classification, and all of the supporting work going around that with the care pathways, models of care, and everything else, that we can actually have something tangible to say, this is what this is what you do, and this is how you care for these patients. And we've never had that before.
Yeah, the stigma is very, very real. I was speaking to a head of another nonprofit organization, and she said that in a different country, and she said that they actually encourage patients, if they're going to be potentially having surgery, to maybe not get the diagnosis before the surgery, because then the surgeon doesn't often want to see them. And it's like, oh, that's so backwards, and just that's very worrisome, because obviously as a surgeon, you should want to know what you're getting into and whether a person has yeah. When I was working as an anesthesiologist, this happened so often in the middle of the night. You're doing an add-on case and they would say, yeah, the person is healthy. And you look at them and you're like, they're not healthy. They just haven't been to the doctor in 20 years. They have all these conditions, but they're not diagnosed. They're not managed. So not having a diagnosis and not trying to work towards managing it doesn't benefit anybody.
Exactly. It's very frustrating, and there's lots of things that need to improve and get better.
And as you know, we end every episode with a hypermobility hack. Do you have a hack you can share with us?
Goodness. I would say the one hack that's seen me through for now 12 plus years is movement. I went to the gym this morning for the first time since September, but I have been moving daily. I have a little treadmill under my desk. And so I move daily, but that weight-based work is really a huge difference for me. I think my life changed completely when I started focusing on building muscle and letting it to kind of support the job that my tissues weren't doing. I think that, and focusing really on what I'm eating and not thinking of it as a diet, but just really focusing on clean eating and avoiding ultra processed food and doing that kind of thing has really made the difference for me. But everyone is different. and everyone needs to find what works for them.
That's so true for me as well. And like you said, it's the giving your body the building blocks and, finding those things that you can do to slowly start making improvements. That's what I tell my patients all the time. It's not like you're going to wake up tomorrow and feel 100% better. We're trying to make some slow, steady progress. It's not necessarily going to be linear, but at least hopefully we can get to a place where we're significantly better, a year from now or 6 months from now or something. And that building that muscle mass is so huge. So huge. So, well, I'm so grateful to have this time to spend with you. And thank you so very much for coming on the Bendy Bodies podcast. Before we go, is there anything else that you wanted to share? And can you let people know where they can find you?
Yeah, absolutely. I would just like to share, join us in the next year. We are with you. We are partners with you. And we will do our very best to make this change, whatever it will be, as easy for our community as possible. You can follow us at Ehlers-Danlos. You can follow me at Lara.Bloom. Type my name into most things and you'll find me. Our website is ehlers-danlos.com. And very happy to chat to anyone, answer any questions, reach out to me on Instagram. I don't really go onto Facebook much anymore. I'm not on TikTok, but I am on Instagram, definitely not on X. But LinkedIn and Instagram is where you'll find me the easiest.
Well, thank you so much. Again, it was such a pleasure to get caught up with you, and I really appreciate you taking the time.
Thank you so much. I appreciate the opportunity to chat.
Well, that was such a fantastic conversation with Lara Bloom, and I just love hearing about all the incredible things that the society is doing and all the progress that's happening in the research space. I think there's so many reasons for us to be hopeful, and please share the podcast and share this information because there are still so many clinicians who have no idea what it means when somebody comes into their office with seemingly misconnected symptoms and things like joint laxity, GI complaints. So they don't know how to connect the dots. So please share the podcast because this really helps get information into the hands of people who can make a difference in the lives of patients. Thank you so much for listening to this week's episode of the Bendy Bodies podcast with the Hypermobility MD. I have lots of other resources, including my newsletter, The Bendy Bulletin. Check out my website, hypermobilitymd.substack.com. You can help us spread the word about connective tissue disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. Did you know that I offer one-on-one support for both clients and healthcare professionals? Whether you're living with a connective tissue disorder or caring for someone who is, I've got your back. Check out my coaching and mentorship options on the services page at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at Hypermobility MD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find Human Content, my amazing producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statement shared on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider for your care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to chat with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.